Hi, this is Sarah, and we're going to talk about Chapter 21, Issues Related to Human Sexuality and Gender Dysphoria. Here are the objectives for the chapter. And just an introduction, sexuality is a basic human need and an innate part of a total personality of a person. Now, although not all nurses need to be educated as sex therapists, they can readily integrate this information on sexuality in the care that they give by focusing preventative, therapeutic, and educational interventions to assist individuals to attain, regain, or maintain sexual wellness. These interventions are aimed at helping the client attain sexual wellness, regain their sexual wellness, or maintain their sexual wellness. So we can't talk about human sexuality without talking about how it applies to people along the age spectrum. Now, through age 12, by age 2 or 2.5, children know what gender they are. By age 4 or 5, children engage in gender-specific play. Like girls typically will play with dolls or that type of thing, and boys will typically play with trucks. Now, that's not saying that girls can't play with trucks or boys can't play with dolls. But by age 4 or 5, you're starting to see some gender stereotype play. In late childhood and pre-adolescence, this may be characterized by heterosexual play or homosexual play. By age 10 to 12, these kids are preoccupied with their puberty changes and the beginnings of romantic interest in the opposite gender. In adolescence, adolescents relate to sexual issues such as how to deal with new or powerful sexual feelings that they're having, and sometimes these feelings can be very overwhelming. Whether or not to participate in various types of sexual behavior, whether or not to have sex or not, how to recognize love or lack of love, and how to prevent unwanted pregnancy, and also how to define age-appropriate gender roles. Now, in adulthood, this period begins at approximately 20 years of age and continues to age 65. And this period includes marital sex, choosing a marital partner or life partner, or developing a sexual relationship with another individual is one of the major tasks in those early years of this life cycle stage. During this stage, there's also extramarital sex. About a third of married men and a fourth of married women have engaged in extramarital sex at some time during their marriage. Now, these numbers have remained somewhat constant for men, but some newer evidence suggests that the incidence for women may be increasing. And this may be attributed to the fact that women are more financially independent. Before, when women were when their finances were tied to the man that they married, if they cheated on the man and he kicked her out, they had nowhere to go. They had no home, they had no income, and not only that, but they had no chance of having an income. Women literally couldn't work outside the home. And so that really guided whether or not they had extramarital affairs. Now that women can obtain any type of employment they want out of the home, that frees up that avenue for them. That's what they think anyway. And then sex in the single person is another area that is addressed in the age group of 20 to 65. Attitudes about sexual interaction and intimacy vary greatly from individual to individual. Now, some enjoy their sexual freedom and independence, while others really are focused on seeking that intimate marital relationship or long-term monogamous relationship. And you can have anything on the spectrum between the two also. And then the middle years, this is age 46 to 65. Hormonal changes during this period can produce changes in sexual activity for both men and women. Women will start to go through menopause, and some men will start to have problems with their prostates, problems with erectile dysfunction, that type of thing. And those are definitely issues that people in this age group need to or will be faced with and need to deal with. Some of the sexual disorders, there are a lot of them. We're just going to go over a couple of them. Paraphilic disorders. These are the repetitive or preferred sexual fantasies or behaviors that involve preference for use of a non-human object, a sexual activity with humans involving real or simulated suffering or humiliation, or repetitive sexual activity with non-consenting partners. let's see, historical aspects. At certain times in history, various sexual behaviors have been, and to some extent still are, condemned by certain social and religious sanctions. Most individuals with paraphilic disorders are men. The behavior is usually established in adolescence. It peaks between ages 15 to 25, and then it declines to a low incidence by age 50. Some of the types of paraphilic disorders: there's exhibitionist disorder. This is characterized by recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting individual. So this would be the flasher. The fetishist disorder involves the recurrent and intense sexual arousal from the use of other either non-living objects or specific non-genital body parts. So this would be like if you have to have like a stuffed animal to become sexually aroused or something like that. There's a frauderistic disorder. This is the recurrent and intense sexual arousal involving touching and rubbing against a non-consenting person, which, by the way, is illegal. But some people, that is the only way that they can attain sexual arousal. There's pedophilic disorder. This is a sexual arousal from prepubescent or early pubescent children of either sex, girls or boys, equal to or greater to that that's derived from physically mature persons. So with someone who's a pedophile, they either don't become aroused by sexual partners their own age, or they have difficulty becoming aroused with sexual partners their own age, or they completely can't become aroused with sexual partners their own age, and instead they're sexually aroused by children, by prepubescent children. And pedophilic disorder is very, very, very difficult to treat. In some, if you talk to some law enforcement, they say it's impossible to treat. So and obviously it has ramifications for children and society at large. So it's a very difficult disorder to just all the way around. Sexual masochism disorder. This is the recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer. Sexual sadism disorder. This is the recurrent and intense sexual arousal from the physical or psychological suffering from another individual. And then there's transvestic disorder, and this is the recurrent and intense sexual arousal from dressing in the clothes of the opposite gender. Now, I have to say that this book treats masochism and sadism and transvestism as disorders. However, in certain populations in the States, or specifically in the States, but around the world, these are, in certain circumstances, and if you have two willing partners, these are not illegal acts. So for people who participate in them, they're not disorders, they're simply how they express their sexuality. This book calls it a disorder, but in some groups, it is not considered a disorder. So just know that. And then there's voyeuristic disorder. This is the recurrent and intense sexual arousal involving the act of observing an unsuspecting individual who is naked in the process of disrobing or engaging in sexual activity. Okay, so treatment modalities for paraphilic disorders. There's some of them are very difficult to treat, like pedophilia is very difficult, if not impossible to treat. Others, there's some people seek treatment and they have some success, so it really depends. There's some biological treatments. The focus of these treatments is on blocking or decreasing the level of the circulating androgens. Let's see, so they may take medications that decrease the level of androgens, and the goal there is to decrease that sexual drive. There's psychoanalytic therapy. Now with this type of therapy, the client is assisted to identify unresolved conflicts and trauma from early childhood, and hopefully this is going to relieve any anxiety that is preventing him or her from forming appropriate sexual relationships with age-appropriate sexual partners. Behavioral therapy, there are some aversion techniques such as the use of electric shock, bad odors, that type of thing, bad tastes, that type of thing, usually used in combination with exposure to photographs depicting the undesired behavior. So you have a photograph with the undesired behavior, and then you show the photograph to the client, and then after they've seen the undesired behavioral picture, you give them an electric shock or the bad order, or whatever the aversion technique is. And in some people, this has been used to modify undesirable paraphilic behavior. In some people it doesn't work, but in some people it does. And then there's something called covert sensitization. This is a group of behavioral therapy procedures in which an aversive stimulus in the form of a nausea or an anxiety-producing image is paired with the undesirable behavior. So in this type of therapy, you have the patient performing the undesirable behavior, but then you give them an aversive stimulus to produce either nausea or anxiety. So then they tie performing whatever the paraphilic disorder is, they tie that disorder to being nauseous or anxious. Again, works with some people, doesn't work with others. Now, what is the role of the nurse? The nurse may best become involved in the primary prevention process. The focus of primary prevention in sexual disorders is to intervene in the home life or other facets of childhood in an effort to prevent problems from developing. Now, an additional concern of primary prevention is to assist in the development of adaptive coping strategies to deal with stressful life situations. Now, sexual dysfunctions. Usually sexual dysfunctions occur as a problem in one of the following phases of the sexual response cycle. So the normal sexual response cycle is phase 1 is desire, phase 2 is excitement, phase 3 is orgasm, phase 4 is resolution. Now, and with sexual dysfunction issues, you're going to have a problem or a dysfunction in one of those 4 areas. Now, historically, people are really squeamish about talking about sex or even admitting that sex exists. However, it's a normal human need. And obviously, considering that we're having a population explosion and millions and millions and billions of people live on Earth, people have sex all the time. So previous to the 1900s and specifically the 1960s, sex was really taboo. I mean, it was very, very taboo. And even among husbands and wives, it wasn't talked about a lot. Obviously, they had children and procreated, so they were having sex, but they just didn't talk about it. Now, in the 1960s, there was a sexual revolution, particularly in America, but in the world in general, there's a sexual revolution. And so the cultural changes that occurred during this sexual revolution of the 1960s and 70s came an increase in people talking about sex, and specifically about people conducting scientific research into the sexual physiology and sexual dysfunctions. And Masters and Johnson pioneered this work. They are just absolutely the pioneers of sexual science studies. And they did a lot of studies on human sexual response and treatment of sexual dysfunctions. Now, the different types of sexual dysfunctions that there's erectile disorder, there's female orgasmic disorder, delayed ejaculation, early ejaculation, and then female sexual interest arousal disorder. So with erectile disorder, this is characterized by a marked difficulty in obtaining or maintaining an erection during sexual activity, or a decrease in erectile rigidity that interferes with sexual activity. With female orgasmic disorder, this is characterized by a delay in or an infrequency of or just a complete absence of orgasm during sexual activity for the female. There can also be a reduced intensity of orgasmic sensation for the female. With delayed ejaculation disorder, this is characterized by a delay in ejaculation or a marked infrequency or absence of ejaculation during partnered sexual activity. With early ejaculation, that's the recurrent ejaculation occurring within 1 minute of the beginning of partnered sexual activity or before the person wishes it. And then female sexual interest and arousal disorder is characterized by a reduced or absence of frequency or intensity of interest or pleasure in sexual activity. And the thing is that if you have one of these disorders between sexual partners, it can really truly affect their whole relationship. And so for the people that this affects, one, it affects their whole relationship, and two, if they live in a social culture where they can't talk about sex, they're going to have this huge problem that they can't talk about or treat. And some of these disorders have treatments, and so it can really affect certainly their relationship with their partner, and then that bleeds over into how the family functions. Now, other types of sexual dysfunction, you've got male hypoactive sexual desire disorder. This is the deficiency or absence of desire for sexual activity on the part of the male. There's genital pelvic pain and penetration disorder. This is where there's a difficulty with vaginal intercourse and attempts at penetration, and this is really, really painful sexual intercourse. Pain is felt either at the vagina, around the vaginal entrance or clitoris, or deep in the pelvis. And this can definitely have an effect on the relationship between marital partners or partners in general, because you don't want to have sex if it's going to cause you pain, and so this can really cause some problems, and especially if they don't want, if they feel like they can't talk about it and there's no help. So a lot of what we do as nurses is just provide an avenue for people to talk about what is going on in their sexual lives. And then there's substance or medication-induced sexual dysfunction, and this is where the person experiences pain, impaired desire, impaired arousal, or impaired orgasm that develops after the ingestion of a substance or medication, after a dosage increase, or following the withdrawal of the substance or medication. So that could be either street drugs, or this can be a prescribed medication. Now, some predisposing factors to sexual dysfunctions. You've got biological factors. There's sexual desire disorders, and this is where you have decreased levels of serum testosterone that may be associated with hypoactive sexual desire disorder in men. There can be elevated levels of serum prolactin that may be associated with diminished libido in both men and women. And there are certain medications like antihypertensive, antipsychotics, antidepressants, anxiolytics or anti-anxiety meds, and also anticonvulsants, as well as alcohol and cocaine that have been implicated with hypoactive sexual desire disorder. With sexual arousal disorders, certain medications, those with antihistamine or anticholinergic properties, may contribute to a decreased ability for arousal in women. There are various medical conditions like arterial sclerosis, diabetes, temporal lobe epilepsy, and multiple sclerosis that can cause erectile disorder in men. And then some of the medications, we already talked about that. Some of the medications that have been implicated in erectile dysfunction include those antihypertensives, antipsychotics, antidepressants, and anxiolytics. And then chronic use of alcohol can also be a contributing factor. Now, within orgasmic disorders, there's some medications like SSRIs may inhibit an orgasm in women. Some medical conditions such as depression, hypothyroidism, diabetes can cause decreased female sexual arousal and orgasm. There are biological factors that are associated with delay in male orgasms that include surgery of the genital urinary tract. So if they have surgery for their prostate, or if they have surgery on their bladder or urethra, this can cause erectile dysfunction. Where am I here? Okay, neurological disorders such as Parkinson's disease, and then other disorders such as diabetes can also cause males to have problems with orgasms and delay male orgasm. There is also some medications like SSRIs that have been implicated. Local infections such as prostatitis or a degenerative neural disorder such as multiple sclerosis can also be implicated in the etiology of early ejaculation. And then with sexual pain disorders, the organic contributing factors to painful intercourse in women include an intact hymen, pediostomy scar, vaginal or urinary tract infection, ligament injuries, endometriosis, or ovarian cysts or tumors. Infections and prostate problems may be contributing factors in men. Other factors are psychological factors. A number of psychosocial factors have been associated with sexual disorders in men and women, and these include religious orthodoxy. This would be if they belong to a religion that has some pretty strict strictures on sexual activity, past sexual abuse, financial, family, or job problems, so that would be increased stress, fears of pregnancy or becoming pregnant, chronic stress, anxiety, or depression, age-related concerns, and then relationship causes like current physical, verbal, or sexual abuse, the presence of extramarital affairs, or suspecting your partner is having an extramarital affair, or you are having an extramarital affair, the client is having an extramarital affair, desire or practices different from the partner. And so that's when two people might be marital partners, but they have very different expectations regarding what will make them happy in a sexual relationship. So, assessment. There are a couple different tools for gathering a sexual history. And additional, and whatever realm you work in, if there's a tool that you need to use, your facility will provide you with one, because there's a whole bunch of different ones, so I'm not going to go into all of them. But basically, information needs to be gathered for clients who have medical or surgical conditions that can affect their sexuality, clients with infertility problems, their history of sexually transmitted diseases, complaints of sexual inadequacy, clients who are pregnant, or present with other gynecological problems, those seeking information on family planning, or in individuals in premarital, marital, or psychiatric counseling. Some of the different nursing diagnoses are sexual dysfunction related to depression and conflict in relationship, or certain biological or psychological contributing factors. Ineffectual sexuality pattern related to conflicts with sexual orientation or variant preferences. Now the outcome, basically our outcomes are going to be based on whether or not the client can correlate stressful situations that decrease sexual desire. They can, without discomfort, communicate to their partner about their sexual situation. They can verbalize ways to enhance sexual desire and verbalize resumption of sexual activity at a level satisfactory to their self and partner. They can correlate variant behaviors with times of stress, be able to verbalize fears about abnormality and inappropriateness of sexual behaviors, express desire to change the variant sexual behaviors that they may be having, participates and cooperates with an extended plan of behavior modification, and expresses satisfaction with their own sexuality pattern. Planning and implementation. Nursing interventions for the client with a sexual disorder is aimed at assisting the individual to gain or regain the aspect of his or her sexuality that is desired. The nurse must remain non-judgmental and ensure that their own personal feelings, the nurse's personal feelings, attitudes, and values have been clarified so that they don't interfere with acceptance of the client. Client and family education is a huge part because, again, yes, we talk about sex a lot more, but in some regards we don't talk about human sexuality, which it's a really interesting dichotomy because there's so many sexualized images and topics and whatnot in the media. However, when you're talking about two people, in particular partners, talking about sex between the two of them, there's still this notion that you shouldn't be talking about sex. So it's really an interesting dichotomy. So with regards to client and family education, we'll do a lot of education on the nature of illness, what the normal human sexual response cycle is, and so that they know what is normal and what is abnormal, types of sexual dysfunction, causes of sexual dysfunction, types of paraphilic disorders with their causes, and then some symptoms with sexual dysfunctions and paraphilic disorders. We want to teach the client to practice ways of sexual expression that are healthy and legal. Relaxation techniques if anxiety is part of their problem. The side effects of any medications that may be contributing to their sexual dysfunction. The effects of alcohol consumption on sexual functioning. And then also we always want to be educating about sexually transmitted diseases. Support services. We want to provide appropriate referral for assistance from a sex therapist if needed. Evaluation is based on the accomplishment of whatever your outcome criteria is, and depending on what the problem is, you're going to have different outcomes that you want. Treatment modalities. For hypoactive sexual disorder, there's testosterone therapy, cognitive therapy, relationship therapy, sensate focus disorders. For erectile disorders, there's group therapy, hypnotherapy, testosterone. There are some drugs now, Viagra, Cialis, and Levitra are the ones that they're really pushing on TV. There's also penile implants and penile pumps that can be implanted. For female and more male orgasmic disorder, there's sensate focus exercises, early ejaculation, retraining. And then for genitopelvic pain and penetration disorders, these folks need a complete physical and gynecological examination so they can find out if there's a physical problem that can be treated. Education of the woman and her partner regarding the anatomy and physiology of the disorder. And then identification and treatment of any relationship problems. Let's see, we just talked about that. Now, gender dysphoria, gender identity. And so the next couple of slides are gender dysphoria and sexual orientation. The book treats gender dysphoria as a problem to be treated. However, currently in our culture and in some parts of our culture, it's not a problem to be treated. It is simply how people are born. So I'm just going to talk about this, but I'm not talking about it as a problem to be treated. I'm only talking about it as some people are born with these feelings. So now, gender identity is the sense of knowing whether you are male or female. That is the awareness of one's masculinity or femininity. Gender dysphoria occurs when there is an incongruence with the biological or assigned gender and one's experienced or expressed gender. So this would be someone, for instance, who is born a male, but they feel that they are female. So the prevalence of gender dysphoria is estimated at 1 in 30,000 men experience gender dysphoria, and 1 in 100,000 women experience gender dysphoria. Now, so most are biological males desiring reassignment to the female gender. Let's see. The individual has a self-perception of being the opposite gender. They don't feel comfortable wearing the clothing of their assigned gender, and they often engage in cross-dressing. Oftentimes they find their own genitals, the genitals they were born with. So if they're male and they were born with a penis, they find that penis repugnant because they feel that they are female. They may repeatedly submit to requests to the healthcare system for hormonal or surgical gender reassignment. And depression and anxiety in this population is very common. And so you always want to be assessing for anybody about depression and suicidal ideation. But in those who are gender dysphoric, depression and anxiety is very common because these are very emotional, obviously very emotional and very conflicting issues. And then if they are not in a social construct that is very supportive and supportive of them figuring out how to navigate this gender dysphoria, that only adds to the depression and anxiety that they may feel. So treatment issues with this client population. Some seek therapy to learn how to cope with their altered sexual identity. Some desire hormonal therapy and then surgical gender reassignment. If they decide on gender reassignment, the individual commonly is required to undergo very extensive psychological testing and counseling. The individual may be required to live in the role of the desired gender for up to 2 years prior to surgery. So they can't just walk in and have surgery 2 weeks later. I mean, this is a very long process. In this 2 years, hormonal therapy is initiated during this period and will continue following the reassignment surgery. Okay, variations in sexual orientation. There's homosexuality. This is a sexual preference for individuals of the same gender. And then there's lesbianism, and this is used to identify female homosexuality. So some special concerns, and this is special concerns for anybody who is having sex, homosexual, heterosexual, any sex at all. Sexually transmitted diseases is a huge concern, particularly HIV disease, and I would also say the herpes simplex virus, because those viruses, because they're viruses, we don't have antibiotics for them. And so we have some antivirals that can make, for instance, we have some antivirals that can make a herpes exacerbation last for a shorter amount of time and maybe make the symptoms a little less painful. However, it doesn't get rid of the disease. And so, so with almost any population that you talk to, we need to address sexually transmitted diseases. Other special concerns, discovery of their sexual orientation, fear of being rejected by parents and significant others, discrimination within society, and then recently gay marriage and whether or not marriage to their chosen partner will be legally recognized, and all of the benefits that go along with recognition of marriage. Now with bisexuality, this is this is a client who engages in sexual activity with members of both genders, sorry, and it's more common than just exclusive homosexuality. Okay, back to STDs, sorry. STDs refer to infections that are contracted primarily through sexual activities or intimate contact with the genitals, mouth, or rectum of another individual. They may be transmitted from one person to another in either heterosexual or homosexual contact, and external genital evidence of the pathology may or may not be manifested. So what this means is that these diseases can be transmitted through either heterosexual or homosexual contact, and they may be, the person might be infected with the disease, and they may have evidence of the disease, like they may have sores or whatnot on their genital areas, or they may they may be carriers of the disease, and they may spread the disease without having any outward manifestations of the disease. So and so that's where it gets really dangerous, because you know, most people are like, well, I'm not sick, you know, I don't have any sores, or I'm not running a fever or anything like that, you know, I'm good, but they're not good because they're spreading their sexually transmitted disease. STDs are at epidemic levels in the United States in all age groups. There are STDs in teenagers, young adults, college campuses, married couples, and also in the, I don't want to say elderly, but like over the age of 65. So across the age spectrum, you have sexually transmitted diseases because people of all ages are having sex. Let's see. So, epidemic levels in the United States. The nurse's first responsibility in STD control is to educate clients who either may become sexually active or are sexually active, and then if they're in one of the at-risk groups of having contracting a sexually transmitted disease infection. Prevention of STDs is the ideal goal, but early detection and appropriate treatment is considered a realistic objective. So lots and lots and lots of education in the various populations. And then you also want to give out information about the different types of STDs. And these include gonorrhea, syphilis, chlamydia, genital herpes, genital warts, hepatitis, and then AIDS and HIV. Let's see, we already talked about that. And again, prevention is the ideal goal. So a lot of your education is about preventing the spread of STDs, but also what are the signs and symptoms of each different type of STD that that will be a prompt for someone to seek early treatment. So, and the goal of that is that they will be treated early so that they can't spread the infection to others.